Well, welcome everyone. I can't even keep track of how many of these we've done so far, Tim, but this has been kind of now an annual tradition. This was one of your other great ideas that's really kind of taken off. So I've been fortunate enough during this whole run of Aspen Super Bowl debates of having my Kansas City Chiefs actually typically play in the Super Bowl. This will be the first year that my Chiefs didn't even make the playoffs, so I'm kind of I saw your post earlier today about your long wait for your Dallas Cowboys. So I'm in your boat. I feel your pain this year. Our Chiefs really didn't do much, but on that vein, I think we have several hundred people that have registered for this webinar across the globe, actually across the across the ocean. We have presenters and panelists from here in the U.S. and a few internationally. So this is going to be a great event as the NFL is becoming a global sport. I think interventional pain and our Aspen and ISPN brand, they're also becoming an international brand. So really look forward to a real diverse array of topics today and really some nice collegial, but I think kind of passionate kind of viewpoints on either side. Tim?
No, Dawood, thanks for those comments. I agree. And, I think the Cowboys next year is our year. So I'm feeling really, really good about that. I think next year we're going all the way. I will say that, the Super Bowl debates have been great. We've had great discussions. I remember several of those. We've had some really friendly discussions. We've had a little bit of controversy and people getting a little aggressive in their responses. I think tonight we'll see some of all that. We'll have an analyst panel after every debate to give you their thoughts, much like we would in the Super Bowl itself. And, I think Dalwood's going to go over our sponsors here briefly, and we're going to kick off the first panel. Dalwood?
Yeah, I mean, you see the agenda here. Thank you to our sponsors, Boston Scientific, Vivex, Spinal Simplicity, SPR, and Nalu. So we'll kick off with our first topic. I actually had this situation come across in my clinic today. So BVNA versus multifidus stimulation in patients with multifidus atrophy and modic changes. What do you do? So I'll kick it off to Jordan to lead this discussion.
All right. Hi, everybody. Welcome to the quarter one of our Super Bowl debates. Super excited to be here. And tonight I'll be moderating on behalf of Boston Scientific. We're going to be talking about vasovertebral nerve ablation, or BVNA, and in comparison with multifidus stimulation for patients that have multifidus atrophy, but maybe also modic changes. Where do you take this patient? You see them in clinic. They present with their axial low back pain. You're now at the point where they're refractory to conservative management of physical therapy and basic injection techniques, and it's time to move on to something a little more robust, a little more advanced. And so tonight I'm excited to have Dr. Kevin Buzz Barrett out of the West Coast and Scripps in San Diego, and Dr. Kiran Patel, who will be presenting on either side. First up, we have Dr. Kevin Barrett. And I ask you, Dr. Barrett, you see this patient in your clinic. What do you think? Where are you going with them, and why? Is it multifidus stimulation or BVNA first?
Thank you so much for the introduction. Really, really appreciate it. So I'm Buzz Barrett again. Very important topic. Obviously, we don't have time, so I'll get right into my argument pro basivertebral nerve ablation. So first and foremost, from a practical standpoint, basivertebral nerve ablation is really not as big of a surgical commitment as multifidus stimulation. There are no implants. We're not burning any bridges. In that same vein, it brings us to procedural risk. If you look at infection rate with BVNA, no infections in either the SMART or the Intercept trial. In contrast, implanting a lead is always going to carry some risk of infection. In fact, if you look at data from the Reactivate-B trial, 3% of devices were removed due to infection. Aside from infection, other adverse events are going to be more common with multifidus stimulation. Data from the Restore trial, so multifidus stimulation, adverse event rate of 23% at 1 year, and the Reset trial, about 30%. In contrast, 5-year combined data from the Intercept and SMART trials shows a 6% adverse event rate. Most commonly, transient leg pain self-resolves after 6 weeks. Next, I want to talk about the theory and basic science behind the pain generators. The idea of the vertebral end plates as a potential pain generator has decades of basic science research. We know from histological studies the vertebral end plates are richly innervated with nociceptors. There's a proven biological basis for a pain generator. when we're discussing multifidus dysfunction. And although there is certainly growing basic science literature, the multifidus being a primary pain generator is a little less well defined. Some basic science work actually shows that the fascia surrounding the muscle has a lower pain threshold, higher pain ratings than the muscle itself. So although I certainly agree with concepts and mechanisms of multifidus dysfunction, and am in no way doubting its importance, the fact of the matter is the idea of the vertebral end plate being a pain generator is just more scientifically established at this point in time. In addition to basic science concepts being more well understood, the diagnosis of vertebrogenic back pain is more straightforward. Modic type 1 and type 2 changes, these are binary biomarkers, easily identifiable on MRI. Of course, you can see multifidus atrophy on an MRI, but we see this in almost everyone at a certain point. And from the studies themselves, the main inclusion criteria is oftentimes based off of physical exam maneuvers. Physical exam maneuvers are user dependent, they're imperfect. The prone instability test, for example, has a specificity of about 57% for lumbar segmental instability. So when we're comparing physical exam maneuvers for diagnosis versus MRI findings, like with vertebrogenic low back pain, there really is no comparison. Additionally important, clinical research. If you look at the clinical research, you're going to see similar long-term data, both very positive. Where BVNA really stands out is the speed at which people see improvement. Restore trial for multifidus stimulation, patients saw a 16-point improvement in ODI, 3-point improvement in VAS at 1 year. In the Intercept trial, patients saw these similar results to this at 3 months. In the pain world, time to relief does matter. And if 2 interventions are going to provide equally effective, durable relief, faster onset might help prevent unnecessary further interventions, fusion surgeries, etc. And I think where BVNA is really starting to pull away from a research perspective is really the growing body of non-industry funded research. Been about 5 studies published in the past year and a half, similar results. And finally, from a patient perspective, I think BVNA is usually an easier pill to swallow. When I'm talking to a patient, and I think they might benefit from either, and I discuss the procedure, they almost always elect for a basivertebral nerve ablation. The idea of an implant, even if it's temporary, is oftentimes a bigger leap for patients, certainly a longer term and more time-intensive commitment. So I just want to summarize in general, BVNA, I'd go for this over multifidus stimulation in this population, safer based on adverse event rates, has more well-defined anatomic basis, objective biomarker, starts working faster, more robust evidence in the literature, and it's an easier pill to swallow. Thanks.
Amazing, comprehensive, robust, well evidenced. I'm going to give Dr. Kiran Patel out of New York 1 minute to prepare her rebuttal, and then I would like her to immediately transition to her 4 minutes of her con statement in support of multifidus stimulation, restorative stem with patients with multifidus atrophy. Dr. Kiran Patel.
Awesome. Well, for that, I think that was many relevant points, but I think the biggest point here, I mean, I do both BVNA and, obviously restorative neurostimulation, but the major point is that BVNA really is silencing the alarm without fixing the fire. Reactivate really is putting out the fire. I'm going to let you take a minute to let that sink in. But the truth is that in the majority of patients with chronic lower back pain, although they may have modic changes, it's rarely that is the single pain generator. It's really the degenerative cascade maintained by the loss in neuromuscular control and mediated by multifidus atrophy that keeps the patients in the state of chronic lower back pain. I have to respectfully disagree with my colleague here. There are about 650 studies regarding the role of multifidus dysfunction in the perpetuation of chronic lower back pain. So this is quite well studied. And, we really need to stop looking at our patients as we need, answers right now, this Amazon now expectation. We need to start talking about improving what they look like in 5 years and in 10 years. And when we're focusing on silencing the alarm and not fixing the fire, we're really not doing them a justice of their long-term benefit. So that's my simple rebuttal to the high points of my colleague's presentation. But what I would say is, I think Spike Lee said it best when he said, do the right thing. And our field in interventional pain is really coming of age, right? In spine, we've spent decades doing the fast thing, the easy thing, the reimbursable thing, keeping the patients on that, kind of treadmill. Reactivate really allows us to do the right thing by restoring the stabilizer system and changing the long-term arc of their chronic lower back pain. Again, BVNA is silencing the alarm without putting out the fire. Reactivate is putting out the fire and breaking that degenerative cascade. Reactivate is the only therapy that directly addresses multifidus dysfunction, which is as evidenced by all of this basic science research, both in the physio world and animal studies, really the underlying cause of chronic lower back pain. And we see that when we create this, spinal instability and mechanical stress, that's what leads to the end plate damage and the modic changes. And then, if we isolate and we treat modic changes that we may see in a given time, what's going to really end that degenerative cascade for that patient? Again, what's their 5-year going to look like? What's their 10-year going to look like? BVNA really destroys the nerve to mask pain signals from damaged end plates. And this is palliative. It's not really doing anything to address the ongoing problem. I'm going to give some analogies from other fields in medicine, just to put in perspective, what we as a field have been doing, and kind of this idea of chasing the pain generator and trying to, dump water on the fire. Cardiology didn't stop for heart failure at diuretics. They pursued therapies that reversed cardiac remodeling, right? Pulmonary didn't stop at bronchodilators. It built a whole world of pulmonary rehab. Every mature specialty evolves from symptom control to remission, and spine is finally catching up. And again, to that Amazon Now crowd, you need to think about this. If you need a knee replacement and the surgeon, you go to them, she doesn't waste your time and talk to you about acupuncture and genicular nerve ablation. She tells you, I can fix your knee with a replacement and you'll get long-term relief and restore a function. And none of these patients care if it takes 3 months. So why use a destructive Band-Aid when we can fix the underlying problem? Pain medicine as a field won't survive with ongoing Band-Aids. We really need to do the right thing and not just silence the alarm, but put the fire out. And that's what I have to say.
Thank you, Dr. Patel. Do you care to add some commentary, either one of you, about some of the data and looking at the robustness of either of your therapies 5 years down the line?
Yeah,
I have some exciting. I have some exciting stuff. A little spoiler alert. So we're about to publish the 2-year data from the Restore study, which for those of you who have not read that, you need to read that. It is comparing restorative neurostimulation to conventional medical management. And this is the crossover arm that was, allowed to cross over after 1 year, and looking at them. And we have something in pain medicine that has never been spoken about: number needed to treat. And for those of you who are not familiar with what that is, the number of patients who need to be treated in order to have a particular effect. And so we're I hope you look forward to seeing that and presenting it. There is a number needed to treat in pain medicine for 50 or greater pain relief of 1.9 after 2 years with restorative neurostimulation. We have never had that with any therapy in pain medicine. Similarly, there is a decrease of 15 points on an ODI with an NNT of 2.1. We've never had numbers like this for any therapy. And we certainly don't have that with the data for BVNA, because we don't have data that's comparing it to standard care for out to 12 months, or even beyond 3 months, essentially, when people were allowed to cross over.
Thank you, Dr. Patel. I think Dr. Barrett and I can both feel your passion through the screen. Dr. Barrett, do you care to prepare your rebuttal for 1 minute?
Yeah, I would very much like to. And so we're saying a lot of things here, and I thank you so much for eloquently laying it out. I think you did a great job, and I certainly agree with your points in concept and theory in general. We are pain doctors at the end of the day. This is a pain management group. We treat pain. A lot of what we do is putting out fires, and that is helpful. I think some of your points about what happens to these patients 5, 10 years out if you're not fixing the underlying problem, Well, we know what happens 5 and 10 years out with basivertebral nerve ablation. That data has been published for years. We see the 10-year data at this point. We know these patients have sustained pain improvement. I'm not sure where the clinical data is that restoring the multifidus long-term is going to prevent further degeneration of the spine. I don't think you can actually say that at this point. And the reason why, from the Intercept trials, which is similarly designed to your Restore trial that you were discussing, the robustness was so profound that an independent data management committee allowed the crossover group to get the procedure after 3 months. So we don't have that 12-month data because the study was shut down for ethical concerns because BBN did so well.
Amazing. A lot to unpack. We're going to turn it over for commentary and impressions from Dr. Ashlyn Brown and Dr. Kristen Jarzenbeck. And I thank you both, Dr. Patel and Dr. Barrett, for your impassioned arguments.
I think this debate has been such a compelling, I guess, back and forth of BBNA versus patients with motor changes. And I think what you really have to bring to mind is that we're really talking about the same patient. You know, somebody who has both motor changes and underlying multifidus atrophy. So I think in looking at the patient with both of these vertebrogenic pain generators and the multifidus atrophy, the real question becomes which intervention is the best to address the primary driver of their symptoms and whichever leads to the most meaningful improvement of the pain and their function. So as Dr. Barrett said, you know, BBNA being very effective in reducing the pain and motor changes, suggesting in-plate mediated nociception, and for some patients, reducing that inflammatory pain alone can significantly improve their function. But then with Dr. Patel speaking on the multifidus stimulation, on the other hand, which may offer some more direct functional restoration by improving the spinal stability and motor control, particularly in patients with muscle inhibition and deconditioning, which might perpetuate the disability. So I think rather than asking which therapy is superior in isolation, thinking about the more clinical relevant question of which intervention best addresses their primary pain generator. And I think Dr. Patel, in my opinion, really hit the nail on the head. Even though Dr. Barrett, you did an excellent argument, it definitely made me question and think a bit deeply. My concern is always, what is the primary pain generator, and can we address that rather than slap a Band-Aid on something? So I'd love to hear Dr. Jarzenbeck's perspective.
Yeah, so let me preface what I'm about to say by saying I don't do multifidus stimulation in my practice. We actually, to my knowledge, don't even have a representative here in Austin where I practice. I do a fair amount of BVN ablation. Anecdotally, in my practice, it works well for the right patient. And like Dr. Brown just alluded to, these patients are all the same. I mean, these two different procedures are for the same patient. I'm very data driven, so I'm really excited to see the new data that Dr. Patel is talking about and read these up and coming studies about more of these regenerative and restorative therapies that are available to these patients. It's really nice to be able to sit down and look at a patient and say, I have something that I can offer you that is not just, it's not just covering up the issue and making it a little bit less loud for you. It's actually going to address the root cause of your problem. I think I still need to see a little bit more evidence, and I need to maybe see a couple of patients in my own practice go through this therapy before I can really latch on to that. But Dr. Patel, you've done a really fantastic job of convincing me it's something I should consider introducing into my practice. Dr. Barrett, I love what you said about, you know, this is not an implant. Patients love that. You know, a lot of my patients in Austin, they're not excited about the idea of an implant. So that's very positive, I think, for BVN ablation. But at the end of the day, if I can address the root cause and this gives my patient a real chance at long-term, robust relief, can't really argue against that.
Q1 ends. Our analysts give their thoughts. Man, what a great debate. I think you both did a fantastic job. Chris Paul, what's your thoughts?
It was really hard fought. I thought some really great points were made by each party there. I think, you know, it's, I think, probably framing this in a slightly, antagonistic manner. I think it's probably not either or, but probably both and. I think having these conversations up front with patients, saying, yeah, you have these motor changes, we can treat this, but the underlying problem may be kind of a longer term fix. So I think it's a little bit of both and probably hedging my bets with that. But Tim, Dawood, what do y'all think? Who gets the win for this?
So I think it was 7-7 after Q1. I think both of our speakers did a fantastic job because they use data, and data is our currency. So I give you both an A+. It's a 7-7 tie after Q1, sort of like when Kelsey dropped the pass for Kansas City last year, could have won the game for him. So I'd say it's a great debate. Dawood, last thought, and then the next topic.
I think it was a tough battle. Kieran's kind of the established, all-star quarterback, and Kevin's the young up-and-comer, kind of the hot guy rookie. So it was tough, but he held his ground against the more seasoned veteran. But I think it was good. I think both therapies, I think they're both great. I think what we need to do is, we kind of have gotten lazy where we kind of get to either do a test injection before we do something, or a trial before we book these therapies. You can't. You have to make the right decision. You implant it or you ablate it. So this is a very compelling and important conversation that you're all facing. So thank you, everyone. On to quarter two, Dr. Golovac will be moderating another really interesting topic on advances in intradiscal therapies, nucleus pulposus supplementation, and talking about the Viadis procedure, amongst other things. So Dr. Golovac, representing the U.
Hey, Dawood, thank you very much. We're up 10-7. So, hey, listen, we have fingers crossed here. Thank you again for everybody participating in this great event at Super Bowl at Aspen. I mean, this has been going on now, like Dawood said, for years. Unfortunately, Mahomes and his team aren't going to be available to be in the Super Bowl this year, but hey, someone else will. This is an incredible opportunity to share some great understanding of what the anterior column is all about. And we just heard from an excellent group of panelists that really have tried to support the understanding of where to differentiate. There seems to be a lot of new interest in the anterior column. And when individuals like your patients come into the office, we understand that almost 43 to 45% of those individuals actually have anterior column pain. So is it multifidi? Is it vertebrogenic? Is it discogenic? And if it is, what do you do about it? Are there long-term effects? Are there long-term therapies? I have two excellent panelists today that I just have a tremendous amount of respect for. Dr. Naidu and Dr. Kolodny have been friends of mine for many, many years. And anterior column pain and intradiscal therapies has been one of my passions. So I'm going to start off by asking Dr. Naidu here, what is the value and the understanding of utilizing a supplement, much like Viadisc NP, to help curtail, mitigate, alleviate, hopefully supplement the degenerative cascade that exists in the anterior column? So I'm very interested to hear what he has to say, and then obviously Dr. Kolodny's rebuttal on that at the present time. So take it away, Ramo.
Thanks, Stan. Thanks, everybody. I'll just start off by saying go Pack Go, especially to Dr. Dickerson. But to your question, Stan, yes, I'm going to break this up into three parts. The first being, let's talk about where we were historically with the disc, what Viadisc NP is, and then where we're going. So the history, as many of you know, and Dr. Kolodny has been a big part of this over the decades, is there's degeneration of the disc. Can we do something to undo that? And for decades, we've tried injecting all sorts of different substances, whether that was saline, PRP, chymopapane, different substances. We went into the disc and started burning annular nerves with the IDET procedure. We did biaculoplasty, etc. And yet our outcomes were mixed. It's not to say none of those things worked. We've had patients who did have decent outcomes, but overall, it was a mixed bag. And what Viadisc NP, which is really one of the only available major novel intradiscal therapeutics on the market available to you right now, what it is taking from the disc for the disc. And the idea is they grab cadaveric nucleus pulposus, micronize it so that it's injectable, and allow that to be injected intradiscally, of course, for our patients. And while the original product had biologic material, they learned by force or by choice that that was not necessary, and that the biomechanical and the biochemical composition of the Viadisc NP does not need to include any cells. and that more of the emphasis has been on the proteoglycan content, which basically draws in fluid, water, and therefore is able to rehydrate and potentially stall or reduce the degeneration of the disc. And not only is that potential there, but we've seen actual improvements in low back pain, which is obviously what we're looking for when we do a lot of our pain therapies. And so why Viadisc NP really stands out in this market right now, which I think is a fascinating market. I'm so glad it's coming back too. The intriguing thing about Viadisc NP is that the evidence is building. I said it years ago at an ASPN, evidence is currency. Tim just said it as well. We now have 2-year studies with the Viadisc NP product. We have just completed enrollment in the Australian study called Ascend, which is a sham-controlled trial versus Viadisc NP, and we now are enrolling for an American study. So with this development of evidence, you are now going to have, as a practitioner, as a provider, data to back up what you are doing in a safe and effective manner. And so that's why the next 5 to 10 years is going to be extremely exciting in the intradiscal market, and why I think Viadisc NP right now has created a great enough moat to be beyond even what we've done historically, but also what may come from competition.
Well, thank you very much. That's extremely well said. Aaron, you and I have been in many a cadaveric lab together, and you have expressed some concerns about intradiscal therapies, of which I will not restate what your quote has been stated before, because you and I both know it's humorous, but I'll respect you on that, my dear friend and colleague. But what do you have to say against Dr. Naidoo as to how the therapies have existed in the past, where are we going in the future, and why don't you think that this is a valued treatment for patients?
Well, thank you, Stan, and I want to thank Tim and Dawood for inviting me, and Ramo, excellent presentation. So for my 1-minute rebuttal, I simply want to say that I use Viadisc NP. I've used it for years. I'm part of the current USRCT, but there are some problems with the product. It's a cadaveric nucleus pulposus allograft. So there's at least a theoretical risk of infection or graft versus host reaction. Saline is used as the diluent, and as you know, patients in other studies have had significant treatment response to intradiscal saline, which may explain partially some of the treatment benefits of the product. The evidence base currently, now I know there's more evidence coming out, of course, but it currently consists of 3 publications, only 2 independent studies, one of which has been published at 12 months by Doug Beal and the other one by Costandi. And that study had a 21% dropout, which is significant. And the other study, the Azim study in older patients, only followed the patients out to 6 months, and that's all we have currently. There are other available treatments without these risks and with a much larger evidence base, including autologous PRP and autologous bone marrow concentrate. So that's my rebuttal.
I had a feeling you were going to state some argument against Viadisc NP. But being a naturalist, as you are, and being a naturalist like I am, you know, when one is thirsty, one drinks water, right? I mean, and if you're going to have a disc that's degenerating, and much like Dr. Naidoo had stated, you're going to utilize a substance like the causative factor of the problem to help restore what may be an imbalance to be dealt with, because there are other products out there. There are many other products in the market that you and I are both participating in studies for, but they haven't realistically demonstrated their overall efficacy at solving thirst, much like a glass of water. So please give us some understanding as to what the value would be in utilizing a substance which isn't nucleus pulposus. And then I'm going to let Ramo come at you with darts and hammers and nails for your rebuttal answer there.
All right, I'm gonna take my 4 minutes now, Stan. Viadisc NP is a cadaveric nucleus pulposus allograft. Okay? It's harvested post-mortem. It's then lyophilized. It's rehydrated with saline, and then it's injected into the degenerative disc. It's very simple, wonderful procedure. I like it a lot. But this product really was initially intended to be combined with live cells. And that was studied in the excellent VAST trial that Doug Beal published in 2020. But the regulatory pathway to approval of a combination product proved daunting, and the nucleus pulposus version, the NP version that is cell-free, is the currently available version, the extracellular matrix alone. This matters because disc degeneration is not simply volume loss. It's a progressive inflammatory disease involving immune cell infiltration and matrix dysfunction. Adding cadaveric matrix alone may not fully address that biology. The addition of living cells, to me, makes sense. Now let's talk about donor tissue concerns, Stan. ViaDisc NP is a cadaveric tissue. Cadaveric donor screening is inherently limited. It's much more easy to screen a living donor, like for placenta, than a cadaveric donor. Now, nobody screens cadaveric donors better than Vivex. That's their core business. But unlike live donors, characterizing exposure history, symptom evolution, and latent infection risk is more difficult. And not with Vivex products, but the literature does talk about transmission of tuberculosis, Hep C, bacterial discitis, HIV, and other viral diseases from contaminated allograft tissue. Although rare and never reported with ViaDisc NP, the consequences could be catastrophic, and the risk is more than theoretical. Beyond infection, donor variability is substantial. Degenerative disc disease is not completely age-dependent, and donor nucleus pulposus may already have reduced GAG content, impaired hydration potential, or elevated matrix metalloproteinase activity. Compounding this, ViaDisc NP is a non-viable allograft that retains donor cellular remnants and the possibility of mismatched HLA antigens, creating at least a risk for host versus graft immune response, particularly in patients with higher Furman grades, where patients are least equipped to tolerate inflammation. So let's examine the clinical evidence for a minute. There are 3 publications using ViaDisc NP, but only 2 independent clinical studies. Both are single-arm, unblinded, no controls. Participants were graded at baseline using modified Furman, yet no follow-up MRI was performed on any of these publications, leaving us with no objective structural outcomes. In Castandi, younger patients were enrolled, mean age of 44. Out of 28, only 22 reached 2 years. That's a 21% dropout. Pain improved early, then worsened gradually after 6 months. Azim's study showed improvement in a Medicare cohort of elderly patients, mean age of 70, but these patients were only followed for 6 months. So together, these studies leave durability unresolved and effectiveness unpredictable. So where does that leave us? Yes, there is early signal that ViaDisc NP is effective in treating painful degenerative disc disease, but it comes from small, uncontrolled studies with no objective confirmation, unclear durability, attrition bias, and biologic uncertainty. Innovation deserves enthusiasm, but adoption requires evidence.
Well said, Professor, well said. But we know there's no perfect therapies for any of our clinical conditions, even the old historical epidural steroid injection. So if the better part of valor is to at least have something that can assist, help, and improve, I'd like Dr. Naidu to help build the case as to why this is a sound and beneficial treatment for degenerative disc patients.
Perfect. I'd love to respond to Aaron's comments. So number one, he made the supposition or the proposition that the cellular product, which had good data from the VAST trial, would be superior to the ViaDisc NP product, which is omitting the cells. And as he mentioned, the disc is a biological environment. It's not just something where you just need to pressurize it and hydrate and everything's going to be okay. Yet it's interesting, the ViaDisc NP 6-month outcomes were better than the FAST study's outcomes at 6 months. number one. Number two, you had concerns about infectious diseases, and that's absolutely a real deal concern. However, I invite everyone to come to Miami and see the Vivex facility and understand how they process tissue. Viadisc NP is one of hundreds of products that Vivex produces, and clearly these issues are something they take very seriously. And to date, there's not been one transmission of disease through their tissues, through the processing of any of their products that I am aware of. And we certainly have not seen that with Viadisc NP. And then your third point, Aaron, which is phenomenal in that, yes, you're right. The Viadisc NP pilot was 6, 12, and 24-month outcomes. We are, as I said, finishing enrollment with Ascend. We're going to have that sham control trial data out of Australia coming out soon, and the American RCT is ongoing right now. You're concerned about the MRI results after treatment and not being published. Unfortunately, that's a major problem in our entire field. So with Vertiflex, we had imaging at 5 years, and quite frankly, there was no major change in canal diameter. With multifidus dysfunction, as mentioned of Q1, we don't see reversal of atrophy or fat in multifidus muscles after multifidus stimulation. And quite similarly, what's interesting is, I can't say for the entire Viadisc NP pilot, but certainly in the patients that I treated in that study, we didn't see any major changes or rehydration or reductions in Fearman or modified Fearman's grading. But yet the clinical outcomes improved, as you know, from pain scores and ODI. So this is a really common theme where we may not see radiological benefits, yet clinical outcomes that support what we do.
Well, clearly, I mean, we have positives and negatives on all of our therapies, and we have to determine what best suits our patient needs, right? We have to figure out what is the best therapy to help their ongoing clinical degenerative conditions that all of them suffer with. So I'd like to welcome Dr. Gill and also Dr. Francio and ask them to give our reactions on both of your debates. And hopefully they're going to give us a both thumbs up and a U, because we're up by 17-10. So that's good.
All right,
thanks for
everybody.
the game update.
Yeah, hope you guys can hear me. So Vinny Frenzy here, and this is going to be the Aspen Super Bowl debates Q2 reaction. So we're going to do this properly. We're going to do the top 10 highlights so far.
And I'm Dr. Benjamin Gill, aka the best Manning brother. I'll kick off our highlights countdown with number 10, the opening drive. It was clean, methodical, and without a fumble. Think Tom Brady, first possession. Amazing work setting the stage with a history of intradiscal interventions. Dr. Naidu.
Number 9 is no trick plays, no unnecessary risks. Dr. Naidu demonstrated the key fundamentals of the debate with clear explanation. He even invited us to go to Miami to see the production facility. Maybe we can go there and celebrate the Hurricanes win.
Oh, number 8, mechanism of action explained of both Viadisc NP and the addition of living cells. That was explained very clearly and calmly by Dr. Kalani. That's pure film study, knowing exactly why the play works before you run it.
All right, number 7, everybody, the outfit highlight. Dr. Kalani, looking classy tonight. That's just not any game outfit right there. That's Super Bowl confidence, my friend.
You gotta look
sharp. Look at him. He's in Paris. My goodness.
Number 6, patient selection, over and over again. That's red zone discipline right there. Because even the best play doesn't work if you run it on the wrong down. Great work by both presenters discussing the pros and cons.
Number 5 was the big hit of the night so far. Dr. Naidu dropping the code of the evening. Evidence is currency. Boom. That was a clean hit. No penalty, momentum shift. And that's how you swing a game.
There you go. Number 4, no overpromising, no ignoring limitations. Both presenters actually protected the ball and won the turnover battles. Excellent execution.
Number 3 was the audible at the line. When the discussion required adaptation in real time based on the counterpoints, veteran level football showed up right there. Both presenters experienced clinical judgment. Nice work for both of you.
And number 2 is a broad highlight of this quarter, a high-level, respectful discussion that actually helps to move the field forward. It's not just a highlight, that's a Super Bowl moment right there. And we want to see more of these tonight.
Well said.
Now we have number 1 now. So drum roll. Let's give it up to Dr. Golovac running this Q2 debate like a veteran referee in the playoffs. No delays, no chaos, and believe it or not, everybody, no flags thrown.
Wow.
Not yet.
Man, what a great reaction. That is awesome. I can't wait to
You guys
hear what
win. That was awesome.
they're going to say now. Oh boy, here we go.
That was the best.
All right, Chris Paul, what do you think?
I mean, between the spirited debate and then the highlight reel afterwards, I just loved every minute of it. I mean, I want to give it to Vidas and Dr. Naidu. I thought he did a fantastic job. I'm going to have to give him the points on this one, though.
Elwood?
I'm gonna give a slight edge to Dr. Kolodny. If it wasn't for his little microphone issue, it would have been a landslide. Ramo, you know, as the Packers probably gonna fall short, so did he today.
I think Golovac did a fantastic job of moderating. So I'm gonna give him the sportsmanship award. I think Kolodny, I was expecting him to come out with a slow running game, like just pounding out a yard or two. He came out throwing the bomb. He's throwing flea flickers. He's throwing all kinds of reverses. And, I think he was ahead for a while. But I think, Aaron, at the last moment, much like, I think happens a lot to my favorite team, Ramo snatched victory out of the jaws of defeat. By the last minute data.
Hail Mary. Is that Hail Mary there, Tim?
I think just like Roger Staubach to Drew Pearson against the Vikings, I think the Hail Mary was successful, and Ramo barely edged the game out by a nose. So great job, everybody. I think that was a fantastic second quarter. And Dawood, it brings us to halftime.
Yeah, halftime. Well, that recap was going to be hard to beat. I should let them just take the halftime over. Dr. Francia and Dr. Gill have other careers in their future, I think. So halftime report, Dr. Mercer, Dr. Varty, and Dr.
Hey guys, you hear me? Okay, I don't know if my
We can hear you, Chris.
I'm getting an echo, but I'm gonna first comments on.
Melissa and Jason, you take over. Christian's having the audio difficulties.
All right. Well, that was fantastic, guys. Great job. Nicely done. So, these debates are just so great. I feel like I just want more. And I could spend all day just watching guys and Ben and Vinny. You guys did a fantastic job with your reactions. I just want more of them. So if you're feeling the same craving as me, here's where we can get more. And believe it or not, we're already planning our 2026 ASPN annual meeting, and it's only 6 months away. And thanks to those who have submitted your topic discussion, we are super excited about what's ahead of us. And also, I want to highlight a few things. Come early this year, because we want to get the most out of our time together. And on that Thursday, July 16th, we're going to expand our program in a few very meaningful ways. In the morning, we'll have our hands-on lab. We're going to launch the second annual Neurotech Horizons in the morning. If you missed it last year, Neurotech Horizon is ASPN's innovation platform. That's where we unite clinicians, industry leaders, engineers. That's how we drive the next phase of innovation in neurotech. And Eric and I worked really hard on this year. It was very well received. We had a standing room only. And this year, we're expecting to be even bigger and greater. Our APP course is going to be on Thursday this year instead of on a Friday, so we can allow more APPs to participate in the main meetings on Friday, Saturday, Sunday. For future leaders, this year, we're introducing a brand new Young Innovators track. So it's going to begin with the poster podium session on that Thursday night with a welcome reception. And we're going to have a targeted programming for all the young innovators throughout the entire meeting. And that's focusing on your career development and long-term success. And we're going to build the future leaders right there at the ASPN annual meeting. Lastly, there's a new program that we're going to launch in a few months, probably in March of 2026. It's called a Mindset. MINDSET, Mindset. So it's mentorship in neuroscience and development. It's our newest ASPN mentor-mentee initiative. More to come. Stay tuned. Jason?
Melissa, great recap. And gosh, the quarter one, man, that was something. I so enjoy the dialogue between our colleagues, leveraging data. I think we're an evidence-based space, and I think that the more that we get into it, it's really going to require us knowing the evidence. And
right.
I thought first quarter was great. If you're not doing BVN or multifidus muscle rehabilitation, you should, because I think there's really good evidence for both. When we think about intradiscal procedure, Ramo, Dr. Kolodny, they did a tremendous job. I don't know what the score is actually. I don't know if it was 7-7 or 10-7, or I don't know what it is now. I'm from Indiana originally, and I would have to say go Bears. So I'm hopeful that they can edge out the Packers in the upcoming games this weekend. Regarding Aspen in Miami, I think it's the premier meeting. I think we all have invested a lot of time and effort and energy and blood, sweat, and tears to ensure that it is the premier meeting. And I think that, part of that comes with an understanding of what we can offer outside of other meetings that may be that may monopolize or allow where you could go spend some time. And we've spent a lot of time on the lab this year. And I think the lab within Aspen has been the premier lab, the training lab for a number of years. We're going to have an ultrasound option. We're going to have potentially a regenerative medicine option, which would be new. We're going to combine the fellows and autonomous providers this year as well. Obviously, we'll host minimally invasive spine techniques along with neuromodulation. And I think we really pride ourselves on the fact that we really have one of the best faculty to attendee ratios. So you're not just going in and seeing something as a standoff from the procedure, you're actually getting your hands on it. I think that's also critical. And then I know Chris was going to talk a little bit about this, but our pain space is evolving. And I know when I graduated fellowship over a decade ago, what I'm doing now in my practice is certainly different than what it was back then based on the innovation that we've had in our space. And a lot of that comes down to learning on the fly and this concept of continuing medical education. And that comes, I think, also to the need for more robustly creating structure surrounding these minimally invasive spine techniques. And so I know Aspen has created a very robust inaugural minimally invasive certification program. And for those of you that read the Aspen newsletter, there was some discussion about why I think that is critical, especially now with a lot of the headwinds that we have in minimally invasive spine. But I know that not only is the lab hosting attendees for learning, but we're also having our inaugural exam for the minimally invasive spine certification. I think that's really an impactful event. I think it's going to be a landmark event in our space, and it's just going to continue to grow up. So I really appreciate Dave Dickerson with his work on that, Tim and his leadership, and Dawood for having the vision.
That was great.
Back
Thank
to
you,
you.
Jason. So speaking of, we have 2 more sessions coming up. We have 2 more quarters, and they are going to be about the spine decompressions. And we have SPR for 60-day PNS as our quarter, as Q4 as well. So Tim and Dawood, do you have anything else to add before we kick off Q3?
No, I just want to say great comments by both of you. I'm sorry we didn't hear from our beloved president, Krishnan Chakravarthy, but we may get him after the next quarter. So thank you very much, Dawood. Any thoughts before we go back to the next quarter?
No, here on the stretch run, the second half is where a lot of the excitement starts. So thanks, Dr. Pope and Dr. Murphy. And let's jump into quarter 3.
So I will pop on for the moment. This is Dr. Bailey Klassen. Dr. Patterson is supposed to be moderating this session, but I think he had some
I can jump in here.
technical difficulties. Thank you, Dr. Syed, if you want to pop on, because you know, as I'm the con, I may add some like subtle hints in as the con. So yeah, we better have a nondescript moderator in. So if you would take over, have at it.
Yeah, so I think I'll jump in for Dr. Patterson here. Dr. J.D. Williams is going to give us the pro onto the Q3 topic, beyond decompression. Treating HLF is only part of the story, and instability requires Minuteman. Dr. Williams, thank you for joining us.
Thank you, Dr. Syed. Yeah, first of all, I want to say go Broncos. Got to get that out of the way. And I'll just kind of jump right in. So, the ligamentum flavum, thickness, hypertrophy, whatever you want to call it, we know that it's an important contributor to a patient's pain presentation. Obviously, it's a very important therapeutic target in a lot of our practices. But what I want to try to convince you of in 4 minutes about is that ligamentum flavum thickness hypertrophy is really serving more as a primary indicator of broader spinal instability. And in and of itself is probably a big contributor to dynamic instability. So to have this conversation, we first need to define some things. What is a thickening ligament? There's hypertrophy, there's buckling. There's true with hypertrophy, it's a true increase in thickness of the ligament, whereas with buckling, it's more of a dynamic picture, right? The lumbar segment's collapsing down, predominantly due to disc space narrowing, and then that ligament is essentially folding into the canal. So to critically examine this, let's take a walk down a lot of different biomechanical data. If you go down the road, what you'll find is, again, going back to studies 10, 15, 20 years or more, you'll find that there's a very strong association between evidence around a thickened ligament being closely tied to disc space narrowing. If we fast forward to 2024, there's a really insightful study by Dr. Yabe, and that group sought to sort out this whole debacle between hypertrophy and buckling. A really simple but elegant study. They said, let's look at the same specimen. Let's look at it on MRI. What is the thickness on MRI? And then what is the actual thickness of the tissue itself? What they found is that, yes, there are two different distinct phenomena. There's buckling, there's hypertrophy, and they're sort of coexisting in a lot of our patients. But the more exciting takeaway for me about that study was that the MRI often overestimates the true objective thickness of the ligamentum flavum. So the key takeaway there is that not all thickened ligaments on an MRI are truly hypertrophic. If you take that thought and carry it out a little bit more, that means that if you're doing or taking a decompression only mindset, a large proportion of patients might not be good responders to that, because guess what? The ligament doesn't truly need the bulking. So keep in mind that you could potentially be tricked into thinking, but if you're just basing purely off MRI and only thinking or not thinking about the broader instability mindset. That same paper also, again, underscored the importance of ligamentum flavum hypertrophy thickness with advanced disc degeneration, which again, you can make an argument that once the disc starts to fail, that's where all this other instability comes into play. Another study I want to just quickly touch on, a really insightful study, is one done by Dr. Yoshua. That group, I should say, they looked specifically at the relationship between hypertrophy and lumbar segmental motion in the aging spine. And they actually did a really interesting thing. They excluded patients who had disc space narrowing. So essentially, they were only or excluding patients with buckling, right? Because the segment was preserved. Statistically, again, they found a strong correlation between hypertrophy and disc degeneration. But more importantly from that study, they showed that, of course, age correlates with a thickened ligament, but angular instability actually predicts the degree of ligamentum flavum thickening. In fact, they concluded that angular instability is a risk factor for ligamentum flavum hypertrophy. And that's in line with a lot of epidemiological data we have that says, yes, there's this causal chain where you have spinal instability that causes excessive mechanical forces, and then that drives this pathological process of ligamentum flavum hypertrophy. So to summarize briefly, there's, regardless of what you think is going on with the ligament, regardless of why it's thick, the ligamentum flavum thickness, that issue is really more a marker of, again, broader instability, if not the clinical endpoint of spinal instability. It's clearly associated with many things: an older patient population, disc space narrowing, which, guess what, is a form of vertical instability. And it's also, according to the study I just cited, a form of angular instability. What I just described is my bread and butter Minuteman patient. That therapy is particularly good at balancing those different types of instability. So one more quick conclusion. I'm not disparaging decompression. Dr. Patterson and I are big proponents of that, but just knowing that a lot of your patients will benefit from decompression. But if you take this broader approach to instability, there's a lot of patients that would benefit from both, oftentimes in combination.
Hey, JD, great points. And hey, I'm so sorry that I wasn't on there to introduce you earlier. I just was going to talk about how you and I have got to know each other over this past year. You know, I view you as one of the young up-and-coming studs out of Boise, Idaho, and have enjoyed my time of getting knowing you, and was so looking forward to this. And I appreciate your pro on this wonderful topic that's sponsored by Spinal Simplicity. But we're going to let Ashley Bailey Clausen come in with the con. ABC being out of Texas, I'm sure she rode in on her horse. She's got her chaps on and, you know, fresh off the ranch. She's ready to kind of give you a run for your money on why she thinks the decompression is needed. Ashley, take it away.
All right. Well, first of all, I've already got my pin ready, but I want to do a couple quick thank yous first. Honestly, I want to thank ASPN for having this tonight. This has been an incredible debate already. This may be the highlight of the night, but that's just me, just saying. I want to thank Dr. Patterson for moderating the session, and I want to thank Dr. Williams for coming up against me like fists up, let's go. So a couple of different things that we did or did not talk about during your session. How bad is that ligamentum flavum hypertrophy? You didn't mention that. You didn't mention how bad is that spinal stenosis? What are their symptoms? Another thing I feel like you totally left out when I'm looking at patients for all of these different therapies is what is their level of instability? So I'm going to pull back what Dr. Patel said in the very first session. Stop the short-term fix. What is the long-term fix? Do these patients just need a decompression, or do they need a fixation fusion at that level? So when we start going into that, if these patients are moving more than 3 to 3.5 millimeters, that is considered unstable. If you refer that to any of our neurosurgical colleagues, they're going to do surgery on that patient. If we don't stabilize that segment with something, we are inappropriate. The data on that is long-standing. You didn't talk about any of the instability segments within that. Then we talked about ligamentum flavum hypertrophy. Sorry, I'm going back to my notes. When we talk about ligamentum flavum hypertrophy, what numbers are you looking at? Are you looking at your own MRIs to decide this patient needs this patient doesn't? When we talk about these decompression surgeries, how much ligamentum flavum hypertrophy are we actually taking away? How much are we propping them up to where that ligament flavum doesn't buckle anymore? Exactly like you mentioned in your research. Ultimately, when we go back to, we're going to have to go back and forth with our spine surgery colleagues about data, hardcore data. What is the gold standard for our patients? Right now, as of today, our gold standard is open decompression and instrumentation. Sorry, I had to let that pause for just a sec, because where is our long-term data compared with that? We don't have that yet. We need it. I don't disagree one bit. I'm the con on this debate. However, this is one of the therapies I am most passionate about, because I think this is one of the therapies that we can do the most good for our own patients. However, it has to be for the right patient. It has to be for the patient who doesn't have spinal instability greater than 3.5 millimeters on a lumbar flexus. It has to be for the patient that doesn't have a severe or critical spinal stenosis on a lumbar MRI. And it has to be the patient that doesn't want or is not a good candidate for an open spine surgery. Those are the patients that are an absolute home run for this therapy. I'm supposed to be the con for this, I know, but I am the biggest moderator for this ever when it is for the right patient. However, I will always be the con when it's for the wrong patient. And those that I've listed tonight, I think are the wrong patient. So with that, Dennis, I will bounce it back to you.
Hey, thank you. So let me throw this out to you guys. You know, I see these patients, and I think a lot has kind of transformed in our field, you know, over the last 5 to 10 years, meaning that we have more options, right? Where before, when we saw patients who had spinal stenosis, we'd say, okay, epidural, physical therapy, you failed, go see our surgeon colleague. But now, you know, we've got the piled, you know, we had interspinous distraction, you know, minus effusion devices. You know, unfortunately, those have kind of been taken off the market, but may make a comeback. Now we've got different approaches to doing a interspinous fixation device. When you guys review MRIs and you see patients, how do you determine which pathway they should go down and why? JD, why don't you take that away and kind of give us some of your input on how you make this choice when you look at an MRI and see a patient?
Yeah, great question, Dennis. And the short answer, first of all, good points to Dr. Bailey Clausen, valid points that I agree with a lot of, to be honest with you. Yeah, and Dr. Pez, it's not an easy decision, right? Because there's so much going on in a lumbar MRI. Dr. Bailey Clausen mentioned gold standard, right? What is the gold standard for instability? Well, I happen to have in front of me, I don't know if you can see this, but this is the White and Punjabi clinical criteria, a scoring system for degenerative instability, right? And if you look at that criteria, there are, let me tell you, there's at least a dozen points of clinical instability: facet effusions, modic changes, spondylolisthesis, like Dr. Bailey Clausen mentioned. Only one of these things, to bring this back to the primary point of the debate, is only one of those things is ligament inflammable hypertrophy. So yes, it is an important consideration, but I'm looking at a broader perspective. I'm looking for all these other signs of instability per the gold standard of instability.
ABC, anything to add real quick, and then we'll move on to our reactions with Dr. Montgomery?
I don't disagree one bit. I do not treat images, I treat patients. So you can present to me all of the criteria you want. However, I'm going to treat patients and their symptomatic pathology.
Perfect. And with that, I want to bring on Dr. Montgomery. I want to get his reactions following this. And then after we tune out, I'm going to probably lose my camera connection again and try to find the simulcast on the Mannings, you know, because Vinny and Gil were so funny tonight. Hopefully next year we have two shows, right? We've got one with the regular debates and another one with them just giving their commentary all night. But take it away, Dr. Montgomery.
Yeah, so I want to say a big thank you to ASPN for inviting us to come here this evening. I'm a consultant from the United Kingdom, so for me, Super Bowl's a foreign entity, so I don't even think I've actually seen a Super Bowl yet. But that's something I certainly need to rectify. And I don't know how I can possibly go after Vinny and Ben and their sort of talk that they've done on it. But I want to say a big thank you to Dr. Williams and Dr. Bailey Clausen for their talks. They were both very insightful, well thought out in terms of their positives. Certainly Dr. Williams had a very, very good start on defining what he considered to be the issues. He used data to drive things forward. And then sort of questioning about whether hypertrophy is the only issue. Dr. Bailey Clausen was very good in terms of her short versus long term and her use of gold standards. So both very, very positive. I've certainly been in the UK. Minuteman isn't as big a thing, but certainly my centre in Leeds were part of the study group looking at Minuteman. So we're certainly familiar with the device and its thing. My sort of thoughts regard to it is always about, is it the right procedure in the right patient and at the right time? You're obviously dealing with groups of patients that have advancing disease, and if they do need major operations, there is a time critical point to it where people can deteriorate and their operative risks and chances of good functional recovery kind of deteriorate. And it's always just about finding that right window for the right patient. And particularly when we're dealing with less invasive versus more invasive, sometimes you've just got to take your chances and get on with the big operation at the right time. And others, it's inappropriate to do so. So it's always a very, very difficult decision to make. But certainly I've found the two talks to be very, very positive. And it's hard to sort of pick a clear winner on the sort of two. The one thing that was never really covered about was about the likes of the cause of some of the instability, like for instance Pars defects, about how that fits into all this. And my understanding was it wasn't appropriate to, and I don't think that was touched upon in terms of the cause for it. But it's always an interesting one.
You want me to speak on that for 2 seconds?
Yeah, you can do.
The particular therapy we were talking on is not indicated for a Pars defect. So
Yeah,
that will
that was my take on it. But
yes, sir. Just to make that clear.
yeah. I think I'm in my last 10 seconds.
Dr. Montgomery, one final thought, and then we're going to go on. Thanks, by the way. What time is it there in Great Britain right now?
It is 2:37 in the morning.
Yeah, that's what I'm talking about. Thank you for being here.
I had a nap before I started.
Great.
Oh, thank you so much for moderating tonight.
So final thought, and then we're going to go to Dr. Paul's thoughts and to the next topic.
So my final thought is I can't choose between the two in a way. Both were very, very positive, but it is very much about right operation, right patient at the right time.
Yeah, I think it was a defensive struggle. The first quarter was a tie. This quarter was a tie. Both did a great job. I didn't feel like anyone was on the attack. Everyone was playing great defense and really doing a great job explaining really the appropriate candidate. So my hats off to both of our Dr. Williams and Dr. Bailey-Clausen. Thank you both, Dr. Paul, and then over to Dr. Syed.
I'm going to have to give it to ABC. I think she had it out in a little by the nose there. But I'm kind of curious what Dawood thinks about all this. And
I'm going to give a slight edge to Dr. J.D. Williams, just a slight. It was, I think he pulled out there at the end when he pulled out that Punjabi paper, when Ashley called him out on maybe not knowing that. And he's like, boom, I got the paper right here. So that was pretty impressive. So I got to give it to him, slight edge there. So great job by both. Let's jump into quarter four. This is where championships are won. We're going to end it up with peripheral nerve stimulation. We have, looks like, what Ditka is that one? It's David Dickerson Ditka. And then we have Dr. Schnur. So this is going to be a great one. And as always, we have Jackie. I don't know who Jackie reps. Jackie reps, are you a Niners fan?
University of Miami. Woo! Like Stan, sorry.
All right.
I mean, Dawood, thank you for bringing that up, because we are now at the fourth quarter, sponsored by SPR, is 60-day PNS underutilized as a first-line interventional therapy. And yes, we are doing this with the football vibes because that makes everything better. But full disclosure, I still only watch college football because I bleed orange and green for the U, and we are up at halftime. So you'll hear really no NFL hot takes from me. That's why. But first, we have Dr. Dave Dickerson from Chicago, proudly repping the Chicago Bulls. I'm sorry, the Bears, rather. And I don't think that, I mean, they are on a playoff hunt, but long shots with only about a 3% Super Bowl chance, according to current future odds. So he's just here to remind everyone that every year is a Bears year until proven otherwise, and talk about why we should start with PNS there. And then we'll have Dr. Schnur, Maricel Schnur, in her full Buffalo Bills gear. The Bills Mafia living proof that playoff life is a strong berth, locked in, and double-digit implied chances to win the Super Bowl. They're seen as much more of a realistic contender this year, sitting around 10-1 Super Bowl odds. So tonight, Bears grit versus Bills grit, the NFC underdog versus the AFC contender. And while neither team is playing in the actual Super Bowl so far, their reps are here today to tackle a different kind of championship, whether 60-day PNS deserves a first-line status. Let's kick off the fourth quarter.
Thanks so much, Dr. Weisbein. Thanks to my partner, Dr. Madi Schnur, for joining me in this debate. And also thanks to the ASPN leadership, Tim Dawood, for having yet another successful Super Bowl of debates. These get better and better every year, and I'm honored to be a part of this one. So effectively, the Bears have been making a lot out of these fourth quarters, and it's really had me reflect on how we take care of our patients, and thinking every time I'm yelling at the TV during the first, second, and third quarter, and most of the fourth quarter while the Bears play, it's, can't we do this any earlier? Do we really got to wait until this last moment to string it together to pull a rabbit out of the hat? Because every year before this year, we never pulled the rabbit out of the hat. And it's a lot like taking care of pain patients. When our patients show up in our practice, they want to win. They haven't had a win. It's been years since they've had a win. They don't think wins even happen anymore. It's a lot like it's been since the 80s with the Bears for a Chicago football fan, for a lot of these patients that come to our office. And we got to start winning, because we are losing big time when it comes to battling chronic pain. If we look at the NIH data, 10 million patients every year, based on the most recent data set, develop chronic pain. Interestingly enough, if you look at the next year, 6 to 7 million still have chronic pain, which means we're helping maybe a third, or maybe nature's helping a third get to a point where they're not in the denominator the next year. So what's that tell us? It tells us that, one, there's not enough of us to go around to help our patients. So when they get to our office, we better put some points on the board and help these patients get a win. That NIH data tells us that there's a reason how 10 years ago, 1 in 5 Americans had chronic pain, and now it's 1 in 4. Because the odds are against us. So when a patient shows up, you might get one crack at it. And if we know that neuromodulation therapies for neuropathic pain states are our most impactful treatments, the sooner we get them understanding that neuromodulation is for them when they have focal neuropathic pain, the better we're going to change these demographics and start to turn the tide the other direction. So for this reason, if we have tools like 60-day percutaneous peripheral nerve stim, we should be employing them as soon as possible. We should have a conversation with patients that come in with neuropathic pain or axial back pain early on, saying, I can't wait to get you this percutaneous peripheral nerve stimulation treatment. And while that sounds like great marketing, it's really an evidence-based statement when we're talking about axial back pain, because we now have the McCormick and Gilmore reset trial that was published this last year in pain medicine that shows that when you take patients and you let them have a percutaneous peripheral nerve stimulation trial, 3 months out, they have a double the likelihood versus the conventional management that we use, including injections and ablations, 55% versus 26% of patients having at least 50% of pain relief still. That gets us to half of our patients doing better. Interestingly enough, that NIH data suggests that that could actually help us turn the tide and have patients doing much better long-term if we get them to these therapies. And that wasn't just about pain relief. We also saw that their function improved. And we can also take the Gorey data and Jonathan in our trial, where we looked at patients with persistent pain after joint replacement, and recognize that while we're replacing a lot of joints in this country, 10 to 15% of patients are having persistent pain afterwards. They're not getting their mobility back. They still have tightness, stiffness, and effectively moderate to severe pain. And what we do have, based on our level 1 evidence there, is that patients who get percutaneous peripheral nerve stimulation for that actually improve in objective measures in a walking tolerance test compared to patients getting sham treatment. So we've got evidence-based peripheral nerve stimulation treatments for patients with these high impact pain conditions. And the question is, when are we going to play like winners today? Or are we going to kick the can and hope that somebody in our office, after they failed the other stuff, then mentions percutaneous nerve stimulation? So what I'd say is it's much more efficient for us to mention it up front and recognize that if you're sending someone to PT, if PT is hard, let them know they can come back and they can get a percutaneous peripheral nerve stimulator lead placed to make their PT better and to make the time they're spending there work out a lot better than for as well. And I would also just say we should put ourselves in our patient's shoes. For these patients with persistent knee pain or chronic axial back pain, we're saying, hey, come back, just 3 visits, a couple weeks apart. In 6 to 8 weeks, we might have you feeling a little bit better, 26% of the time based on the reset data. Now, that's a really interesting thing to offer patients. I'm going to poke you 3 times on each side of your back, maybe 4, depending on how I do things and what I think you need. And we're going to do that 3 times. And then a couple weeks later, you're probably going to notice that your back feels better if you keep coming back to see me. Whereas I could say, do you want to come back next week for your axial back pain? I'll put a little lead right here. You'll leave. And a couple weeks later, as you're working with your physical therapist, you can come back and say thank you to me. And that's an evidence-based treatment that I'm really excited to offer you. And can't you feel my excitement? Don't you want to win? Exactly. Can you feel it? Bears, can we do this? I think we can do it, but we just got to act like winners. And I'm just going to leave with a quote from Mike Singletary, from the great 85 Bears, because I think, when in doubt, quote smarter people that have done a lot more in their time. He says, I'm sure there's a right way and a wrong way. The bottom line is you have to do what you think is right. And then if we fast forward 30 years later, we got our current quarterback saying, the only thing that matters at the end of the day is that you go out there and win. I think that's pretty true. Good news is we've got a pretty good set of offensive plays that we can do now to treat these conditions. All we got to do is actually get out of our own way and play to win.
Thank you so much, Dave. No penalty on the field for your overtime there, but we'll hand it over to Dr. Schnurr. Madi, it's all you. You've got a first down. Take it away.
I'm always so impressed by like just the sheer volume of how much Dr. Dickerson can talk. I love him. Although I wish I believed in the phrase more is more, I don't. And sometimes there can be too much of a good thing. And I'm going to tell you why that is. If we take every patient that comes in our door and we say, you know what, we're going to cure your pain next week with a peripheral nerve stimulator, we're just doing them a disservice. And one of the reasons for that is we're not going to see the same results that we see in our clinical trials. And why is that? It's because we're not spending the time, the effort, the thoughtfulness of choosing the right patient, of talking with them about the therapy, and then leading them through it as a physician really should. They're going to lose out, we're going to lose out, and soon enough our payers are going to realize that we're not doing the right thing. And so I would say that first line intervention is not the role of 60-day PNS, but early in the algorithm, 100% it is. Should I just keep on going for my?
No, Madi, that was succinct and perfect. I would say, a 2-point conversion on that one at the end there for the quick time. Well, thank you guys so much. In the effort of keeping this quarter moving, I'm going to bring on our commentators. So Dave, thanks for that amazing pro, and Madi, thanks for the continued, right thing for the right patient. Thank you so much, Dr. Anuj Shah and Dr. Lawson Smith, for joining us for some hot commentary at the end of this fourth quarter. It was a brilliant battle, but now you guys can give us some colorful commentary on who you thought took that quarter home.
Well, I'll say that Dave Dickerson doesn't read the playbook. The playbook reads David Dickerson. There used to be a Mike Dicka joke, by the way. I think both commentators did a great job, and Jackie, thank you so much. You also did a great job. Tim Dawood, thank you for inviting me here. Great to be here along with my esteemed colleague Anuj Shah. In my thoughts, I thought, Dave, you took a little long to get to the meat and potatoes, if you will. But once you got there, I really do believe that we can include PNS as a first-line therapy. What do we have to lose by this? What are we truly delaying? What is temporary PNS take off the table? Nothing. It's just, can we get insurance to approve it? And I don't know what football analogy y'all have for insurance. I'd love to hear it. I don't have a good one. Otherwise, I'd bring it up. But if we can get insurance to come around to it, I think PNS will do, especially temporary PNS, can do a lot of good. And my quick thought about that is, the sooner we can treat the centralized plasticity that develops because patients have been in chronic pain for so long, I think the better off other therapies will work. What is the best way we can do that? Well, neuromodulation. Let's go, Dave. Let's go. Anuj, I'll turn it over to you.
Absolutely. Well, first off, I'm a big Lions fan, so I'll have to give a shout out to the Lions. They weren't able to make it to the playoffs. I will also give a shout out to the Bears for losing to the Lions right before going into the playoffs, so that's always fun, and definitely fumbling it around in the fourth quarter. But Dr. Dickerson, you did not. I think you started off, I always love hearing you speak, like Dr. Schnurr said, but I think you started bringing up some of the data, and I think that's the biggest point about this debate itself, is if we are going to use it as a first-line therapy, why not follow the targets that are supported by data? So you brought up some chronic low back pain, but actually the data for chronic low back pain, there's actually a little bit better data for post-RFA chronic low back pain PNS. And shout out to Dr. Benjamin Gill, who's also on here for releasing a Neuron Project PNS guidelines here that just came out, and I encourage everyone to read that. Other amazing targets that we do know based on the data is post-amputation pain, phantom limb pain, post-op knee pain. And so these are some things that, I know, Dr. Dickerson, you brought up post-op knee pain, but I think we really need to, if we're going to utilize it early, might as well go for the targets that are already proven. And I think that would be really helpful for our field and continue to generate better and more incredible data. So.
Rock on,
Well,
go Cowboys.
Thank you for that amazing wrap up and reaction. With that, I'll hand it over to the GOAT, the greatest of all time. No Tom Brady. I don't even know who else to think about other than Tim Deere. So with that, without further ado, sir, please take the lead, take this helm, take us home, and let's close this game out on a solid ending.
Jackie, you're way too sweet. I appreciate that very much. I will say though, it kind of remind me a little bit. Let's imagine, the Bears make it to the Super Bowl against the Bills, and the Bears play ball control, and they're winning the whole game. They're controlling the ball, and then at the last minute, Josh Allen comes in and throws the winning score. So I have to give Maddie some points for her rebuttal there. So more is not more always, but both did a great job. So I would say that was a slight victory by David, but I think at the last minute of Josh Allen may have pulled it out here with Maddie Schnur coming in for some great comments there. Thoughts, Dr. Paul?
I think I have to agree with you. A slight edge to Dr. Dickerson. The Bears finally came out on top for this one.
I'm going to go with Dr. Schnur. I know that she's in a tough spot because she's very pro temporary PNS, and for her to be able to kind of think outside of her typical box and show kind of where some other holes lie in that thinking, I think is pretty impressive. So I'm going to go against the curve there, and I'm going to go with Marcella on this one.
Dr. Schnur, we'll give you a final thought here before you go off the screen, and then we're going to have to go to overtime because the game just tied up here for the last moments here.
I love it. Thank you guys for letting me speak. I am so pro 60-day PNS. It is so true. Thank you so much, Dawood. I wholeheartedly agree that there are great targets for SPR and the therapy. I don't think that it's first line. One, because I think anything but physical therapy and maybe some non-opioid medication should be first line. If we're throwing in peripheral nerve stim and neuromodulation the minute we meet a patient, we're doing them a huge disservice.
Great points. All right, well, let's jump into the game is tied. So what happens in the playoffs? We don't have any ties in the playoffs. We go to overtime. So with that, Dr. Blake, take us to extra overtime.
Absolutely. It's really true, Dawood. Every great game ends in overtime with a stunning overtime play, and we have exactly that play for you as we discuss a really pressing question sponsored by NALU, and that is, for patients with axial low back pain without radiculopathy, where does PNS fit relative to spinal cord stimulation or dorsal root ganglion stimulation? And joining me to discuss this, I'm pleased to be joined by Dr. Usman Latif, who is a consensus leader in peripheral nerve stimulation and helped draft our ASPN consensus guidelines. And I'm looking forward to hear you present the case for PNS-based treatment.
All right, thank you so much. When we think about axial low back pain, it's historically been very difficult to treat. There have been some advancements with SCS, but we still have a lack of robust data. There are multiple technologies, though, that have been studied to target peripheral nerves for axial low back pain. So let's start right in the data, the foundational work. There's a 2019 Gilmore study, looked at 12 months data. 67% had an average, were responders. 63% had an average pain reduction in that. Then a few years later, we had Dr. Gilmore et al. They published long-term outcomes in IPM in 2023. They reported that 77% of patients had improvement in pain, disability, or pain interference at 14 months. More than 50% had a reduction in opioid consumption at 14 months. Now, if we dive directly into the data that's specific to perm implants with the micro IPG PNS system, we can look at the Comfort Level 1 prospective multicenter RCT data. 12-month data published by Hathaway et al. And RAPM in 2024. It's 89 randomized patients, 44 patients were axial low back pain, targeting the columnar nerve. Responder rate was 87%. Average pain reduction was 66% in the axial low back pain cohort. That's a nearly 5-point drop on the NRS. Moving forward, took results from the Comfort 1 trial, moved on with the Comfort 2 trial, which was similar, Level 1 prospective multicenter RCT, pulled them together, published them in 2025 in the Chronic Pain Management Journal. Engel, Gutierrez et al., I was one of the authors, 173 total pooled patients. More than 45% were axial low back pain without radiculopathy. Responder rate was 81% at 6 months and an average of 65% pain relief. You can see a pattern here. Then real world data, Rutino, Swain, Hathaway, they looked at real world data from a registry over a 2-year period and identified 61 patients with lumbar medial branch PNS implants. Responder rate was 96%. Average pain relief was 67%. Then in 2025, a large-scale real-world data analysis was done. Hathaway, Rutino et al., I was one of the authors, looked at 2,273 patients. 893 of them were targeting axial low back pain, 93% responder rate, 65% reporting very much or much improved on PGIC. And the data followed patients out to at least 6 months after implant, with some going out to 2.5 years. What about guidelines? The ASPN consensus guidelines for the use of PNS for chronic pain were just published a couple months ago. I was one of the lead authors on that. We had over 30 international experts. The assessment that we came out with was level 1 grade A evidence to support medial branch and cluneal nerve PNS for axial low back pain. So now we have level 1 RCT data, we have real world data, and we have expert consensus guidelines all backing up efficacy. What about salvage for SCS patients? Scribus, Deer, Kelly et al. Published in Neuromodulation in 2025. 21 patients who had SCS and were unable to target their axial back pain were treated with cluneal nerve PNS, 91% responder rate at 6 months with an average of 71% pain reduction. What about healthcare economics? Kelly et al. Published 2025 in Pain Management, Real-World Healthcare Utilization and Cost of PNS with a Micro-IPG System. They compared data 1 year prior to 1 year post-implant. 122 patients cross-referenced with medical claims data. They saw decreased outpatient visits post-implant, 50% reduction in mean total medical cost post-implant, and a 31% reduction in the proportion of patients on opioids post-implant. What about patient safety and comfort? Well, there's some degree of pocket pain in SCS. There's some reports saying that it could be as much as 64% of patients, but across all these RCTs, all the real-world registries, the comfort RCTs, 0 reports of pocket pain. Also, the infection rate in the comfort trials was extremely low. A few minor exit site infections during trials that resolved with oral antibiotics. The thought is that a large battery pocket further reduces this, that is not present here. So because of that, you have less surface area for bacterial colonization. So in conclusion, PNS targets axial low back pain more specifically and even when SCS fails. Robust level 1 RCT and real world data and ASPN guidelines support this efficacy. PNS is cost effective and additionally avoids the cost of replacement batteries that you see in SCS. And PNS is less invasive and carries less risk than SCS, reducing intraspinal risks to 0. And therefore, PNS is preferable to SCS for axial low back pain.
Thank you for that stunning presentation. That was really well done. A hard act to follow, but Sushanth Boda will try. First with your rebuttal, and then what's the con on this?
Yeah, no, for sure. First off, it's always hard to follow Dr. Latif. I think he, like you're saying, is an all-star in our field. And I mean, he brings up some great points. I mean, I'm not here to deny that PNS does not have a role in axial low back pain. It's just a matter of, is it more beneficial or less beneficial than spinal cord stimulation? And I mean, I think you brought some great points, especially recently. There's been a lot newer data that's been published that supports the use of it. However, when I look at it in my own clinical practice, I pretty much look at what's the underlying diagnosis. I mean, we have this term of axial low back pain, but there are so many different variables and diagnoses that fit into that category. So for me, in terms of where does PNS fall into that role, I think of facet arthropathy, and I think of potentially multifidus dysfunction, and then as Dr. Latif brought up, cluneal neuropathy. So I think for those patients that have it, need to have those specific diagnoses to have PNS be efficacious. But as we know, there are so many other applications of axial low back pain that fit different diagnoses, such as discogenic pain, where, you know, we all know the cascade of, you get disc degeneration, causes load onto the facets that can cause other issues of stenosis and other pathologies that PNS, quite frankly, can't treat. So I think it all depends on the underlying diagnosis. And then, as I'll get into in just a second, there's a plethora of evidence that also supports the use of SCS in that space as well.
Excellent. And Dr. Latif, with your rebuttal?
Actually, I think he gets 4 minutes and then I come back for a rebuttal.
Thank you for that. Yes. And Dr. Boda, what is your con statement?
Yeah, perfect. Thank you. So, you know, kind of how everyone said, I do want to thank Dr. Deer and Dr. Syed for kind of giving us the platform and this opportunity. I think our space is growing so quickly that it's amazing that we're able to have this platform and be able to share ideas and discussions. And, you know, in terms of the role of SCS in this patient population, it's not opinion, it's fact that SCS is the most studied, the most established form of neuromodulation, supported by the most RCTs in any other neuromodulation approach. And as everyone said, Dr. Naidu, Dr. Deer, data is our currency. So let's look at what the data shows. Now, first, let's look at evidence hierarchy. So you have to look no further than our ASPN and Neuron consensus statements for non-surgical low back pain, primarily axial low back pain, where spinal cord stimulation was given a grade A with high certainty, high consensus, compared to PNS was given a grade B with moderate certainty and moderate consensus. And why is that? There's two primary studies here that I want to touch on. The first is a systemic review published by Dr. D'Souza in 2023, where he looked at over 29 articles and over 828 patients, where the authors listed it as a level 1B with grade B moderate evidence for PNS for low back pain syndromes. Now, limitations consisted of risk of bias, clinical, methodological heterogeneity, and inconsistent data. And the studies consistently showed modest to moderate pain improvement, but the authors rated it as, quote, very low grade evidence. Now, that does not really scream superiority for me for the role of PNS for low back pain syndromes. Second, in 2021, Dr. Gilligan published a randomized controlled trial comparing PNS to sham, which surprisingly showed no statistical significance in the primary outcome of at least 30% improvement in VAS at 120 days. So that highlights the role of placebo risk and uncertain incremental benefit for the role of PNS. On the contrary, when you look at the data supporting SCS, it's quite the opposite. So, there's definitely 3 or 4 or even 5 studies, but the main ones I want to highlight start off with a distinct study published in Neuromodulation 2023 by Dr. Deer and colleagues, where they looked at BURST-DR, which had a 72.6% responder rate with a 30.1 improvement in ODI. Compare that to Dr. Caparel's study, where he had 2, one published in 2022 in the Journal of Neurosurgery, where they looked at Nevro's 10 kilohertz waveform frequency, as well as in 24 months in Pain Physician, published in 2024, where they showed an 80.9% responder rate at 3 months, 80% responder rate at 6 months, and from a durability perspective at the 24-month mark, an 82% pain responder rate, along with 75% of patients continue to get at least a 10-point reduction in ODI. So not just pain, but functional improvement that we're all seeking. And then more recently, again, in 2024, Dr. White and colleagues published in the NAS journal where they looked at DTM waveform in the role of chronic low back pain. Now, some of these patients did have leg pain. I'm not going to argue that, but their primary endpoint was back pain relief. And their primary endpoint showed a 93.5% responder rate with at least 50% pain relief and a 23-point improvement in ODI. So for axial low back pain, SCS has randomized data with huge effect size that show functional gains, opioid-sparing endpoints, and durability. So PNS has promise, but the evidence quality is currently not as high as SCS, and the outcomes are smaller. So again, I'm not against PNS. I think PNS certainly has a role in the treatment of axial low back pain. I think we as a field need to continue to publish more prospective multi-center RCTs with long-term outcomes to continue to advocate for both therapies in our field. But if the goal is meaningful pain relief with function restoration, opioid responsible outcomes from refractory axial low back pain with a broader diagnosis that we can apply this to, I truly believe SCS has higher quality evidence, higher certainty recommendations, and larger effect sizes. So I think PNS is certainly promising, but SCS is proven.
Thank you for that. And Dr. Latif, do you have a rebuttal for Dr. Boda?
Yeah, so I think these are all valid points. Look, he cited some of these guidelines that are a little bit outdated now, stating that when you look at the data, just looking, previous to 2023, maybe it wasn't quite as robust for PNS. We can see all of the data that I cited today. Most of that was published after that date. And so we have lots and lots of, in fact, we have multiple level 1 RCTs that came out after that date. So I think that's number 1. Number 2, all of this data that's cited for SCS, this is great. I was involved in some of that stuff. The problem is that many of those studies do not focus specifically on axial back pain without radiculopathy, but rather have patients who have back pain that's more prominent than their leg pain. And he did address this, but that's not the same population we're looking at here. Those are different populations, and so we can't extrapolate that to axial low back pain without radiculopathy. And they also had very small sample sizes. So even the ones where they looked at axial back pain only, you're like, for example, like the distinct, if you look at how many were actually randomized to SCS, it might be like a dozen patients or so. So at the end of the day, when you have a patient with SCS, rather than starting with axial back pain, rather than starting with SCS, where you start so far away and have to dial in on something that's so difficult and elusive, it's like trying to complete a 90-yard pass while your QB is getting rushed. Me, I'll take PNS. Put me on the 5-yard line, undefended, I'll walk that ball in.
Excellent insights. I think it comes down to the theme of this whole conversation tonight of both just the right patient, the right time, and the right therapy with evidence backing it. I don't know if there's a discussion section of this. I didn't see it listed. I'm not sure if Dr. Deere and Dr. Selwood, yeah, hello.
Oh, we'll make a few comments. Dr. Blake, great job moderating. I think Dr. Lateef was, he's quoting the great article he just first authored, and he was really, I think, winning the game. And Boda came up with a good offensive challenge, but the last minute, I think Dr. Lateef misquoted one of the SCS studies, which gives error a fumble on the 4-yard line. I think Boda sneaks it out for the championship. That's just my take. Dr. Paul?
My takeaway from this is just that the amount of data that has come into our space in the last 3 to 5 years is just really immense. That's really my takeaway from this. We're able to really, for the first time, have data-driven, patient outcome-based decisions in our clinics, and the treatment algorithms that we're putting out there. I think Dr. Lateef did a phenomenal job. I think Dr. Boda put up his best effort, but I'm going to give a little edge to him. But I think Dawood probably is going to get the last word on this.
Dawood, you're the tiebreaker here. You're the tiebreaker here.
I think it was, it was a battle. This is overtime. The stakes were high. Both were composed. Both really stuck to their guns and showed really good data. I think Dr. Boda had the easier assignment. I think SCS has been around for a long time. I'm going to have to give Dr. Lateef from Kansas the edge, though. When you can quote some studies that you've been part of as part of your argument, I always give it that edge. So I think Dr. Boda, he's going to be on a lot of our papers coming up in the future. I think if we meet again next year, he may get him. But this year, we're going to give the win to Lateef on my end.
Right, Lateef. Well, Lateef's the winner of that debate. Dr. Blake, I think you're the other winner. Great job in the moderation. And what a great way to end the Super Bowl.
Yeah, well,
thank you all for having us. This was fun.
Yeah, I appreciate that.
Yeah, this was awesome.
Great job. Great job. Well, do we have a little bit of announcements or anything like that? I can't remember.
Yeah, I think we have a few announcements to make at the end here. Just a few things coming up. So post-debate announcement we've already made. We're just going to go straight to the end of the meeting. That's these things. Dawood, you want to go through these, or Dr. Paul?
Yeah, I think, we're super excited. ASPN 2026 is right around the corner. We took a look at our hotel block just a couple days ago, and it's almost completely full. So, not to cause any anxiety, but we have another block that we're going to secure, another hotel, but there's still some rooms left at the Fountain Blue. So kind of make those reservations. It's going to be first come, first serve. We're looking forward to having one of the biggest and best Aspens yet in Miami. Submission deadline for abstracts, April 15, 2026. Those top 15 or so abstracts will be presented live on the podium. So we look forward to that. Here's our next Young Innovators webinar, going to be on diabetic peripheral neuropathy, highlighting the SWEET guidelines that were published a couple of years ago, and well as some really important updates on that. So you can register today for that. And our final, if we do, ASPN. ASPN's coming to Amsterdam. So in 2026, October 22nd to the 25th, registration should be live here in the coming days. So, but please do save the date. So we're really looking forward to going back over to Europe. London was a tremendous success, and we're going to build upon that momentum in Amsterdam. I'd like to just close with, giving Dr. Paul big kudos. You really organized, and I guess there was, you would kind of be the general manager of the debate. So really putting together this all-star team, getting the funding, keeping us under the salary cap, and getting us great attendance and viewership. Kudos to you. Great job.
Yeah, no, I think Chris Paul did a fantastic job. Chris, we thank you so much. And this was so well organized, and working together with you to pick the faculty has been fantastic. And just can't tell you how proud we are of all the great things you're doing with the webinar projects.
Thank y'all. Appreciate it.
With that, good night, everyone. Thanks for joining us, and we hope to see you soon.